Thank you very much. I mean, it's a real honor to be here with that's a nice crowd. I see a lot of people that we work every day, especially with the patients, that show us how much we need to improve. And I think hopefully we can do that every day. What I have to talk about is about culture-sensitive communication. And probably you notice from my accent, I may have some culture issues, so I do apologize about that. But it's true that I go myself talking to my patients, talking to my colleagues with difficulties in what is communicating. So sometimes it's easier to feel the same on other patients that did not have the fortune that I had to be able to go through a better cultural adjustment, and that they had to struggle the way I did also time ago. And they have to deal with systems sometimes that it's not favorable, not for anyone, but more when there's barriers there. So basically, I would like that we are able to identify areas of disparity in advanced heart failure and heart transplantation, understand what are the social and demographic factors that interfere with equitable healthcare access, also recognize the importance of cultural sensitiveness in reducing disparity, ensuring quality of care and improving outcomes, and identify novel strategies to reduce disparity associated with cultural communication gaps. So hopefully we can show a little bit about this over the next few minutes, but let's see a little bit about the Affordable Care Act. Always changing health policies is positive thinking, and we always hope that they lead us to a good end. But this new healthcare model wants to provide care that puts people at the center of all clinical decision making, develop a health home concept that provides primary and preventive care that's so important, build a provider network that delivers top outcome at a reduced cost, and this provider network is so important of integrating the tertiary health care system with the community and work together to our patients. And from a population perspective, obtain health and data management with all information that we handle currently. Let's a little bit about health disparity. What it means is significant difference regarding access to care, quality of care, and health outcomes across different racial ethnities and insurance groups in the United States. This is a very unique picture in the United States because of the diversity, which is also the beauty of this community, and also the insufficient access to primary and preventive care. And something that's important is that more than 30% of the direct medical expenditures could be excess cost due to health disparities. So that's important to be able to offer health care to the whole population, how we can do better still. And then it's the concept of the acculturation, because it's not only the fact of being from a different social, but how you're inserted in that culture. So patients who are foreign-born and who do not speak English as their primary language, that's myself, adverse outcomes related to cultural language difference are associated. They have higher risk of adverse outcome independence of race, ethnicity, other traditional markers of disease severity, and biological factors as well have been shown that are increased in these patients. And let's put some examples, and these are examples that come from our clinical practice. Change a little bit names, age, just to protect patients or any, but one of the things is, and I'm glad to see Dr. Honda here, who is one of our colleagues that on a Sunday afternoon when we were rounding together, he comes to discuss with the patient in the online, which was her patient's medical needs, and what's his intervention at that moment in a culturally and patients-oriented manner that then to really change in a major medical decision. And this is a 48-year-old male who came with chest pain and heart failure. Patient only speaks Armenian, recurrent admissions due to chest pain, congestive heart failure, had what it thought could be a non-ST change, no ST myocardial infarction, based on the maltroponing leg. The patient refused the catheterization, and he was not willing to take more medicines. He basically when we talk about lifestyle, he eats Mexican and Chinese diet frequently. Talking to it, when the resident present in the morning, say, well, the patient doesn't want to do things. The reality is the patient had 5 catheterizations. The last was obtained 2 months before admission and showed normal coronary arteries. He has so many medications in a bag in his room that he doesn't know what they are for, that he doesn't want to take more. And he's very receptive to the interventions of our wonderful nurses who explain him what's about diet. And it's only made changes and understanding on what he had to do that makes the difference. So basically the points of poor satisfaction with the patient, risk exposure, health expense that carries associated with this, that interferes with the care. Similar 61 Hispanic female that has been referred for heart and liver transplant. The patient was felt not a candidate before referral due to the high psychosocial risk. He was referred to us when she was much sicker. Patient had pulmonary hypertension, severe deconditioning with massive ascites, and one of the things where we're considering end-of-life options. The patient was only Spanish speaking only. With appropriate treatment, we could compensate him. When talking to him and when engaging with the team of care, say, Doc, I would do anything you tell me. And the patient followed during the hospital appointments. Unfortunately, he remained too sick. And that's one other problem that we see. Late referral, suboptimal psychosocial assessment that interfere again with the care of our patient. And similarly, in a 52-year-old Hispanic male that was referred for heart transplant, and I'm also glad that Dr. Cajigas, Dr. Suarez is here, who help us with this challenging patients where a patient was transferred emergently in cardiogenic shock. The referral cognitive evaluation at that affiliated hospital say the patient had dementia. The patient was initially suddenly deemed not a candidate for heart transplantation due to high psychosocial risk. The truth is that the patient is partially fluent in English. The testing was conducted in English language. And when it was performed by our neurocognitive testing specialist, she performed average high when testing in Spanish. The patient diagnosis of dementia was revoked upon re-evaluation, and the patient was listed for heart transplantation. So inadequate psychosocial assessment that interfere with the outcome of this patient. This is very frequent specific because we are in Los Angeles. This applies to the Hispanic community, but this applies to every minority, everyone that may have a barrier in terms of understanding their own care. So there is several challenges that we have to be aware of that are linked by the acculturation and disparity that lead to overutilization of diagnostic texts, underutilization of evidence-based therapies, development of preventable complications, and also lead to late referrals. All this together lead to higher healthcare costs and also low patient satisfaction. If we see among the minorities, we see the African American and the Hispanics, they have a higher incidence of heart failures compared to white or Asians. Despite that, they still outcomes are more difficult to achieve in a similar way. If we look into gaps in terms of how we provide the care, we can identify gaps at every single level: cardiovascular education with health literacy, cardiovascular risk factors, diabetes, hypertension, hyperlipidemia, metabolic syndrome, cardiovascular care, acute myocardial infarction, heart failure, biventricular paces, advanced heart failure therapies with assist devices. All has been described and published, a lot of them by Dr. Foner, who has been presenting earlier today. So if we look into health literacy, this came out of a study in New York by Dr. Yaz, says that there was 50% of the Hispanic patient, if they say what would be the signs of heart attack, they don't know. And if you have chest pain, would you call 9/11? They don't know as well. These are just very simple things that make a huge change if can be addressed properly. So there is a gap related to the basic healthcare knowledge among Hispanics specifically. And similarly, acculturation and associated with healthcare outcomes, patients that are defined as accultured, they have a higher chance of being hospitalized. That not affecting the study the longer year mortality. But what we see is when we get the patients into appropriate programs where they address this in a similar way towards what are the goals that the patient has to meet, then we see that the outcomes are not different. That's also a study that Dr. Foner was involved in, and that showed that having appropriate resources improve our patients' outcomes. So let's see a little bit about heart transplantation. So we usually see them as a whole, but if we split them into the white, black, and Hispanics, and this is because these are the major components of the three major racial groups. The Hispanics, we can see that they have a higher mortality and waiting list compared to white and black. We'll see here that about 50% higher is the mortality rate compared to white. Patients are sicker at referral, they develop more organ dysfunction rates and have higher rates of waiting list deactivation. However, when they are listed for heart transplantation, they get transplanted earlier for two reasons. One is they have to be listed in a more acute, in a higher waiting list status rate. So they have a more acute need for a heart transplant. When we see into the outcomes with mechanical circulatory support devices, and then we see the 5-year outcomes, similarly we see that for Hispanics and also for the African American, this is less. And when we see the utilization of assist devices in the Hispanics, what we see is a sicker cohort when they are referred to the high volume transplant centers. So as compared to heart transplantation, we see the UNOS database, 14% of these patients will receive a heart transplant, while assist devices is only utilized in 6% of the Hispanic patient, which when referred is the sicker population. So those are factors that has to be further studied and analyzed. And let's see a little bit about how is the diversity in the United States and in California, and what is our. So if we see this is the split of the population in the United States, 78% white, 74% for California. Hispanic or Latino origin have 38% in California as compared to 16.7% in the rate or in the rest of the United States. So certainly the Hispanic population, because of the distribution and the component, there are areas in Los Angeles where it's almost 100% of Hispanic origin. I mean, certainly it's important. It doesn't mean that the other ethnicities are not important. Asians are also growing. We're going to see how fast they are. But certainly resources have to be to be put in order to address this. Let's see how is the distribution of the Hispanic population in the United States. So towards the West Coast, we see that they're the higher component of Hispanics. But if we see what is the variation, like you see in the figure to the right, of from the year 2000 to 2010, if you see the increase of the Hispanic population across the whole United States. So all these factors that we are seeing here, I mean, this is something that it's growing in the United States, and certainly health policies addressing this will improve the health care as well as the Hispanics themselves. We see the Asian also growing across here in California, near the bigger cities. The Hispanics also together are the two populations that have grown the most, with African American and non-Hispanic white stable over time. So to summarize this part, Hispanics are the main minority in California and highest growing group. Minority groups are disadvantages. Hispanics show low health literacy. They benefit from programs such as the GET with the guidelines implemented by the American Heart Association, and the gap still to be closed. So the thing is, can we, from the university perspective, from the academic standpoint, use certain research tools that we have in order to try to go through those gaps. And one of the things that we have been working over the past years with Dr. Deng, we have been working in networks. And network we see from the gene levels, and we also see from a society perspective. There are some papers that have shown that that different process or behaviors that is spread through networks, like obesity. If you are obese, then you have a friend that is obese. It's more likely that your friend is going to be obese, and the friend of your friend is going to become obese as well. Similar with smoking, with happiness, and with infections. So they spread through networks. Yeah, and one of the things that we wanted a few years ago, we looked into the UNAS database, and we just see how is the network in the United States from white, black, Hispanics, and we use certain algorithms that let us map every donor and recipients in the United States, and then try to reconstruct their network. So if you see on the left is the regional map of the UNOS, so it's divided in regions, and we see that we can see that in the state of California and Texas with what we call community, or groups that they're together resembles what the UNOS map that's using the data from the UNOS database. If we look at the zip code level, and this is all transplants in the United States, one of the things that is important, if you see below between Florida and Texas, there is a blue area. So that is not reflected if you see the UNOS region marked between 3 and 4. There is a new region that just self-emerged there that seems that is originated in disparity. When we see the white recipients, you see how populated is this that we can see at network. A network is linked between one side to the other. And then we see that as in the African American, this is less connected, and the Hispanic recipients just much less connected. So this puts people at a disadvantage, because we know that using networks, we are at what we call 6 degrees of separation. So myself from any other person in the world, we're going to be linked by 6 different contexts. This Hispanics and the African American compared to the whites are 11 and 13. That means that the ability of the Hispanics and the black to get into the society and be connected as the white is much, much, much lower. And then when we see how clustered they are, it's half the clustering of the black and the white. This is a great disadvantage, and this is also from a systems perspective, it's very difficult to attach, because despite that we want to spread our words or we want to reach them, there is a network process that doesn't allow us to get there. The other thing is when we see into what is the expected donors and recipient, we see in red that there is less donors and recipients compared to what it would expected, specifically for the Hispanic, and this makes very sense when we understand the network, how the information get to them, and so for how they're able to get into the system. So we can see that network modeling helps us understand the process of organ donation, shows disadvantage connectivity among minority interventions can be modeled using networks concept, and we still need to understand them. We'll look a little bit about the heart transplant activity among Hispanics in California. One of the things that, if you see, that's a statistic from the UNOS database from 1988 to 2013, and then you can see how is Hispanics in the US, that's prediction 1970 up to 2050. So there is a net increase. So if we see a problem right now, if we don't address that, how big that problem is going to be years to come, how much healthcare issues that is going to bring. And this is the Hispanics in California. Across the different heart transplant programs, we see that there is a lot of variation. So that comes at the time of taking care of the regional population. We have to address what is our population. And certainly that's not always reflected, and that's something that we have to also think about specifically now. And after the healthcare reform, we have 61% of the Latinos that are under insurance. They are 32% of the United States population. So we have the 60% of patients that are Latino have no insurance, and then we'll have to we will be able to address their healthcare needs as with the new healthcare plan. So this should bring us an opportunity. It's the opportunity of disparity. It's the opportunity from being good to be great, because we cannot say we are great with all this difference or the deficiencies that we find in the system. And this has to be also understanding the concept. I mean, if we have deficiencies, and this is an example on a Hispanic family, but applies to many others, where survival, wellness of the family first come, they have to deal with so many things, so paying bills, ensuring that you have access for your family and children, that then the last thing that you're going to take care of is own health. So it's not sometimes the patient is non-compliant or the patient doesn't take care of himself. They have so many other problems that they have to take care of that the last thing that they want, I think it's someone else. And this is where it becomes so important. What are the resources that are put in the university? And there's many at UCLA efforts that are being done. One is the recruitment and retention of international medical graduates that has a cultural competency in Spanish, go through cultural competency training as a policy in the university. We have Dr. Cadeiras from the Cultural Neuropsychology Initiative that help us so much with this transplant evaluation and help those patients to become heart transplant because they are evaluated in a cultural component way. We have translation service that are used, and we have our support group specific, Alien Scudero leading the UCLA Hispanic subgroup. We have initiatives on how we can improve the care of our patients by improving our relationship with our patients. Dr. Raya, together with Dr. Deng, have developed the Relational Medicine Foundation, and with that, the Relational Medicine Act, with weekly research meeting to try to see how we can do better. So just to finalize, I think we need to find ways to try to connect disconnected systems, and that's where we're working with the university also with different resources that we have in order to try to reduce those gaps. In summary, we want to provide access to high quality of care for our vulnerable population, that they need the recognition and cultural concordant intervention should be improved to enhance minority outcomes. Strategies should be developed to address cultural and language barrier between patients and healthcare providers, model and personal patient-centered care initiative. One of our patients that is Hispanic, I wanted him to be here, but he couldn't make it actually, and so he sent something to, but basically she was describing what is the importance of his that healthcare be able to be addressed by in a cultural competent way. And I think that's also the major role that all our nurses at UCLA, that they are so great in trying to meet the needs of our patients. I think, yeah.
Hi, I'm Vanessa, and I'm speaking on behalf of my father, Ramon. My dad received a heart and kidney transplant February 9, 2013. Since Spanish is his native language, communicating has always been difficult. So for him, having a doctor that spoke Spanish really helped him feel more comfortable when asking questions or addressing any concerns he had, because there was no language barrier. And he also understood his condition more clearly. My dad's stay in the hospital was quite long. It was about 2.5 months stay. During this time, he had many tests and procedures done. Not always did the staff performing them speak Spanish, but they were always able to obtain a translator, either in person or over the phone. We do believe that having a bilingual staff impacts the overall patient care, because if a patient fully understands her condition, they feel more empowered to make the right decisions themselves instead of always agreeing with doctors and staff. The support group that Eileen has really pulls together the Hispanic community, because they're able to go communicate with one another, share their experiences, and I think any questions they may have. This long journey was made a little bit simpler because my dad and our family had all these types of resources available to us.
Okay, so that was the summary, and hopefully we had made the case and how this aligns to our vision of healing humankind and ensuring that every patient is taken care with the needs that they really need. Thank you very much.